64th of your Apurba is Sastry Essentials of Microbiology, which is about Pertussis, Borderella pertussis. In this chapter, we will be reviewing the virulence factor, clinical manifestation, epidemiology, lab diagnosis, treatment, and prevention of pertussis. Bordetella is a highly fastidious, very small gram-negative cocobacillus described first by Bordert and Gengio in 1906. It's a non-fermenter, belongs to family Ella lignaceae. It comprises of several species. Bordetella pertussis causes whooping cough in children, a highly contagious vaccine preventable bacterial disease characterized by paroxysmal cough ending with a high-pitched inspiratory sound described as whoop. Bordetella parapertussis causes milder form of whooping cough. Bordetella bronchioseptica is a pathogen of domestic animals that causes kennel cough in dogs, atrophic rhinitis and pneumonia in pigs, and pneumonia in cats. Rarely respiratory infections in humans have been reported. Pertussis. Bordetella pertussis causes violent paroxysmal productive cough in children called as whooping cough or pertussis. Virulence factors. Bordetella pertussis produces a wide array of toxins and biologically active products that are important in its pathogenesis and immunity. Most of these virulence factors are under the control of a single genetic locus that regulates their production. Tracheal cytotoxin is a part of cell wall peptidoglycan, which causes damage to the cilia of respiratory epithelial cells. Pertussis toxin is the most important virulence factor. It's expressed only by Bordetella pertussis. PT is similar to cholera toxin in its structure and mechanism. It causes activation of adenylyl cyclase, leading to increased concentration of CAM, which is responsible for producing a wide variety of biologic effects seen in whooping cough. Adhesins play a role in bacterial attachment. Examples include filamentous hemagglutinin FHA, pertactin, an outer membrane protein, and fimbre or pili or agglutinogens. Other virulence factors include adenylate cyclase toxin, dermonecrotic toxin, and bacterial endotoxin. Pathogenesis. Pertussis is primarily a toxin-mediated disease. Bacteria attached to the ciliated epithelial cells of nasopharynx multiply by producing a variety of toxins to cause local mucosal damage and thereby impairs host defense mechanism. Clinical manifestation. The clinical course of whooping cough or pertussis or 100 days fever passes through 3 stages following an incubation period of 7 to 10 days. Catarrhal phase lasts for 1 to 2 weeks and is characterized by common cold-like non-specific symptoms such as coryza, lacrimation, mild cough, low-grade fever, and malaise. It is highly infectious stage. In this stage, both smear and culture are likely to be positive. Paroxysmal phase stage lasts for 1 to 6 weeks. Patients are less infectious. Smear and culture may become negative. It is characterized by specific symptoms such as whooping cough and post-tussive vomiting. Convulsant stage lasts for 1 to 3 months. It occurs following the paroxysmal stage, during which the frequency and severity of coughing gradually decreases. Antibodies may appear in the serum. Whooping cough. Each paroxysm consists of bursts of 5 to 10 repetitive violent spasmodic coughs, often within a single expiration, which ends with an audible sound or whoop. Whoop occurs due to rapid inspiration against a closed glottis at the end of paroxysm. Paroxysm may be precipitated by noise, eating, or physical contact. In between paroxysm, patient may appear to be normal. The frequency of paroxysm varies widely from the several per hour to 5 to 10 per day. Episodes are often worse at night. During this pass, there may be visible neck vein distension, bulging of eyes, tongue protrusion, and cyanosis. Weight loss may be seen, but fever is uncommon. In this figure, we can see the female infant suffering from pertussis. In figure B, we see the colonies of Bordetella pertussis on Regan lower agar. Mercury drop appearance is there. And Gram-stain smear of Bordetella pertussis shows a thumbprint appearance. Now the complications are more common among infants than among children or adults. Pressure effects during the violent spasm of coughing results in subconjunctival hemorrhage, hernias, pneumothorax, rib fracture, and petechiae on face and the body. Pneumonia may develop especially in old age due to secondary infection due to encapsulated bacteria. If it occurs in infant, it is usually due to Bordetella pertussis. Neurological complications such as convulsions, encephalopathy, and coma may also occur. Differential diagnosis: whooping cough like symptoms may be seen with Mycoplasma pneumoniae, Chlamydophila pneumoniae, adenovirus, influenza virus, and rhinovirus. Epidemiology: whooping cough is a highly communicable disease with high attack rate of 80 to 100%, which reduces to 20% in immunized populations. Host: it is exclusively human disease and there is no animal reservoir. Source: early cases catarrhal stage are the main source of infection, even though previously it was believed that there is no carrier state. Recent molecular studies prove that a transient carrier state in the nasopharynx occurs among children following the disease, which may contribute to the spread of the infection. However, there is no evidence of long-term carrier state. Age: whooping cough is predominantly a disease of preschool children below 5 years. As the maternal antibodies are not protective, infants remain the most vulnerable group, accounting for the highest morbidity and mortality. A shift of median age: pertussis has shifted from infants to older children and adolescents in countries with high vaccination coverage. This indicates that pertussis, immunization, or natural infection do not provide lifelong immunity. Mode of transmission: it is via inhalation of droplets by coughing or sneezing or even talking, or rarely through direct contact. Recent outbreaks: several outbreaks have been reported recently, which include the Washington epidemic in 2012 and California epidemic in 2014. Worldwide, the incidence of pertussis is declining. WHO estimated around 1,51,074 cases of pertussis in 2018 compared to more than 20 lakh cases in 1980. Most cases occurred in unvaccinated children, although the global vaccine coverage was 86% in 2018. India: there is a marked decline of disease after the launch of vaccine under Universal Immunization Program in India. In 2016, pertussis was reported from India where cases were 37,274. There is no cross protection to Bordetella parapertussis infection. Now coming on to the lab diagnosis: specimen, nasopharyngeal secretion collected by alginate swabs, direct smear gram-negative coccobacilli and pus cells, culture Regan-Loy medium or Bordet Geno agar, produces mercury drops or bisected pearls colony. Culture smear reveals small ovoid gram-negative coccobacilli arranged in thumbprint appearance. Identification is by automated methods such as Marlitov or Vitek. Detection by serum antibodies is by enzyme immunoassays, and of PCR is by detecting IS481 and PT promoter region genes. Typing of Bordetella pertussis is by serotyping and genotyping. Lab diagnosis: specimen collection, nasopharyngeal secretion are the best specimen, which may be obtained by nasopharyngeal aspiration, the best method, or the per nasal swab. Throat and or sputum specimen are unacceptable. Type of swab used for culture: alginate swabs are the best, followed by Dacron swabs. However, for PCR, only Dacron or rayon swabs are recommended. Cotton swabs are not satisfactory as fatty acid present in cotton may inhibit the growth of the bacilli. However, charcoal impregnated cotton swab stewards may be useful. It is recommended to collect 6 swabs at 1 to 2 days interval to achieve maximum yield. Cuff plate method and post-nasal swabs used before are no longer recommended. Transport: specimen should be processed immediately. If delay is expected, then suitable charcoal-based medium like Amis, Regan-Loy, Jones, Kendrick transport media can be used. Direct detection: Bordetella pertussis may be directly detected from nasopharyngeal secretions by direct immunofluorescence test using fluorescein labeled polyclonal or monoclonal antibodies. Because of poor sensitivity, 18 to 75%, and specificity, it is not widely used. Culture: nasopharyngeal culture remains the gold standard method for diagnosis. Bordetella pertussis is a strict aerobe, grows best at 35 to 37 degrees Celsius. It is fastidious, requires special complex media for primary isolation, such as Regan and Loy medium, Bordet Geno glycerin potato blood agar. Colonies are grayish-white, convex with a shiny surface, appear after 3 to 5 days, described as mercury drops or bisected pearls appearance. Culture remains positive only during the first 3 weeks of infection, that is mainly in the catarrhal stage where the symptoms are non-specific. Culture becomes negative within 5 days of starting of antibiotics. Now the culture smear: gram staining of culture reveals small ovoid coccobacilli tend to arrange in loose clumps with clear spaces in between, giving a thumbprint appearance. Identification from colonies can be done by automated methods such as Marlitov or Vitek. Detection of serum antibodies: enzyme immunoassays EIAs using purified antigens of Bordetella pertussis such as pertussis toxin, FHA, and pertactin are the methods of choice. Demonstration of a rise of IgG antibodies in paired sera or detection of Ig or IgM antibodies provides a definite diagnosis. However, antibodies are also elevated in immunized people. Molecular methods: PCR remains positive in first hour weeks of onset of symptoms. It is being increasingly used in many laboratories, replacing culture because of increased sensitivity, specificity, and quicker results. The most common targeted genes are IS481 and the Pertussis toxin promoter region genes. Other findings: lymphocytosis is common among young children but not among adolescents. Treatment of pertussis: as pertussis is mainly toxin mediated, antibiotics are less useful once the infection is established. However, they play a vital role to eliminate the bacteria from the nasopharynx. Macrolides as a drug of choice: azithromycin for 5 days or erythromycin for 7 to 14 days. Cotrimoxazole is recommended as an alternative in macrolide resistant or allergy. Isolation is in a quiet environment may inhibit the stimulation of paroxysm. Cough suppressants are not much effective. Prevention: chemoprophylaxis. Erythromycin is widely recommended as chemoprophylaxis for household contacts of pertussis cases. Vaccine: whole cell pertussis vaccine is prepared by heating followed by chemical inactivation and purification of whole Borderella pertussis bacilli. Efficacy is good, average being 85%. DBT vaccine in India and many other countries: whole cell WC pertussis vaccine is given under National Immunization Program along with diphtheria toxoid and tetanus toxoid DPT. 3 doses of pentavalent vaccine DPT, hepatitis B and H influenza are given at 6, 10 and 14 weeks, followed by 2 booster doses of DPT at 1.5 years and 5 years. Pertussis component act as adjuvant and increases immunogenicity of DT and TT. Okay. Now, adverse effect: WC vaccine associated with the following adverse effects such as common fever, injection site pain, erythema, swelling, and irritability. Uncommon features like Bordetella pertussis is an encephalotogenic. It is associated with neurological complications, encephalitis, prolonged convulsion, and hypnotic hyporesponsive syndrome. The estimated risk is 1 in 1,70,000 doses administered. Contraindication: because of the adverse effect, WC vaccine is contraindicated in children more than 5 to 6 years of age. Any associated progressive neurological conditions. Children with strong family history of epilepsy, hypersensitivity to a previous dose. Now, the acellular pertussis vaccine composed of pertussis toxoid and 2 or more other bacterial components such as FHA, pertactin, or fimbriac. Though the efficacy is same as WC vaccine, it is associated with fewer side effects as compared with the latter and can be safely given after 5 to 6 years. Available as DAPT along with diphtheria and tetanus toxoid, it is recommended for older children who have missed their primary dose of DPT. So this completes our chapter. In this chapter, we can write short notes on virulence factors of Bordetella pertussis, lab diagnosis of pertussis, vaccination against pertussis, of course. Now MCQs. Mercury drop appearance: a colony of B. pertussis is seen on which of the following culture media? It is seen on Regan low agar. Pertussis toxin is produced by Borderella pertussis. And which of the following is highly infective stage in whooping cough? It is the catarrhal stage. Okay, so this completes our chapter of pertussis. Next, we'll be starting with non-fermenting gram-negative bacilli chapters. Okay, so stay tuned, like, share, subscribe. Thanks for watching.